السلام عليكم ورحمة الله وبركاته طلاب المرحلة الثانية كلية الصيدلة جامعة بابل. Our topic today is lung volumes. Lung volumes are the amount of air exchanged during the ventilation. It can be subdivided into three components. First is the tidal volume. The tidal volume is usually equal to 500 ml, and it's the amount of air that moves into and out of the lung but during the normal breath. While the inspiratory reserve volume is the amount of air that can be inspired forcibly after inspiration of the normal tidal volume, which can occur during exercise or a very deep breath. It is equal to 3,000 mol of air. The last one is the expiratory reserve volume, which is the additional amount of air that can be expired forcefully, and it is about 1,100 cc of air. Approximately 1,200 ml of air always remains in the lung after forced expiration, and this amount of air that remain in the lung after forced expiration is called the residual volume. And this is mean that our lungs are not completely remain without air during or after expiration. And if this happened, there will be a severe collapse of the lung. So normally we require amount of air to remain in the lung, and this is called the residual volume, which is equal to 1,200 mol of air. This residual volume increases with age because there is more trapping of air in the lungs at the end of expiration. And these volumes can be measured by using, these volumes that we were talking about them can be measured by using an instrument called spirometer. Another topic related to the lung volume is called the lung capacities. The lung capacities are completely dependent on lung volumes. It includes the following capacities. The vital capacity, and it is the maximum volume of air that a person can expel from his respiratory tract after a maximum inspiration. After a maximum inspiration, the maximum volume of air that you can expel from your respiratory tract is called the vital capacity. And as you see, it is equal to the inspiratory reserve volume plus the tidal volume and expiratory reserve volume. And it is equal to 4,600 cc of air. The other is the inspiratory capacity, which is the amount of air that a person can inspire maximally after a normal expiration. After you did a normal expiration, the maximum amount of air that you can inspire is called the inspiratory capacity and is equal to 3,500 mol of air. What's the functional residual capacity? The functional residual capacity is the volume of air that remains in the lungs at the end of normal expiration, which is equal to the reserve volume and the expiratory reserve volume, and it is equal to 2,300 mol of air. It is the volume of air that remains in the lung after normal expiration. And finally, the total lung capacities is the sum of all volumes in the lung and is about 5,800 cc. As you see in this diagram, this is the tidal volume. This is the tidal volume which occurs during rest. This is the inspiratory capacity, which is including the resting tidal volume, and this is the functional residual capacity. And these are the respiratory volumes. These are the respiratory volumes. This is the tidal volume. This is the inspiratory reserve volume, which you can have an extra inspiration, and this is the expiratory reserve volume, which represent your ability to have extra expiration, and this is the residual volume, which represent the amount of air that remain in the lung and prevent it from collapse. And this is the total lung capacity, which involve all capacities. Another figure which represent the lung volumes and the lung capacities. This is the tidal volume, which is the amount of air we can inspire at rest, and this is the inspiratory reserve volume, which is the volume we can inspire over the tidal volume, and this is the expiratory reserve volume, which is the amount of air that we can expire over the tidal volume, and this is the reserve volume, which remain in the lung after maximum expiration. As you see, the inspiratory capacity involve the tidal volume and the inspiratory reserve volume. Okay, while the vital capacity involve the inspiratory and expiratory reserve volume. This is the vital capacity, involve the inspiratory and expiratory reserve volume and the tidal volume. The functional residual capacity This is the functional residual capacity, which involve the residual volume and the expiratory reserve volume, while the total lung capacity involve the all capacities of the lung. You can search in the internet for the importance of the lung volumes and lung capacities in the diagnosis and in the line of treatments of respiratory disease, and how these volumes and capacities changed in different type of lung disease. Another topic we have to understand is the exchange and the transport of gases through the lung. The pulmonary gas exchange is conventionally divided into 3 processes, and these processes are very important to maintain a normal respiratory function. These processes include, first, the ventilation, which is the flow of gases into and out of the alveoli of the lungs. So ventilation is represented for gas movement, while perfusion is the flow of blood. Perfusion is the flow of a liquid. It is the flow of blood in the adjacent pulmonary capillaries. So ventilation is concerned with the gases. Perfusion is concerned with the blood in the flow in the pulmonary capillaries, and finally diffusion, which is the transfer of gases between the alveoli and the pulmonary capillaries. And why we are talking about the alveoli and the pulmonary capillaries? Because the real respiratory process occur here when there is a direct contact between the alveoli, where the air is present, and between the pulmonary capillaries, where blood present. So the final step will be a transfers of gas between the alveoli and pulmonary capillaries, so that oxygen will be transferred to the body cells and CO2 will be exhaled outside the body. What is the ventilation? Ventilation refers to the exchange of gases in the respiratory system. There are 2 types of ventilation, which is the pulmonary ventilation and the alveolar ventilation. Pulmonary ventilation refers to the total exchange of gases between the atmosphere and the lung. The whole process of gas exchange between the lung and the atmosphere is called the pulmonary ventilation. While exchange of gases within the gas exchange portion of the lung, which is the alveolar, is called the alveolar ventilation. It means alveolar ventilation is the more specific ventilation that occur within the gas exchange portion of the lung, which is the alveoli. Ventilation requires a system of open airway and a pressure differences so that air will move into and out of the lung. For the ventilation to be successful, we require an open airways so that the gas will move freely, and we need a pressure difference, because if there is no pressure difference, the gas will not pass in and out of the lung. And this pressure difference that moves the air into and out of the lung, it is affected by the body position and the lung volume, as well as by a disease condition that affect the heart and respiratory system. It is not an easy process. It requires multiple factors to act together to produce a successful and effective process of ventilation. And that is why we mention that ventilation affected by body position, lung volumes, and by a disease condition of the heart and respiratory system. Now we can talk about perfusion, and we said that perfusion is for blood. So the term perfusion is used to describe the flow of blood through the pulmonary capillary bed. The primary function of pulmonary circulation are to perfuse or provide blood flow to gas exchange portion of the lung. And I remembers you for the second time that the gas exchange portion of the lung is the alveoli. So perfusion is very important to maintain a normal respiratory function, because it is important to provide the blood flow to the gas exchange portion of the lung and to facilitate this gas exchange. The gas exchange function of the lungs require a continuous flow of blood through the respiratory portion of the lung. The deoxygenated blood will enter the lung through the pulmonary artery, as you know, which has its origin, the pulmonary artery, in the right side of the heart, and enters the lung at the hilum along with the primary bronchi. The pulmonary arteries branch in a manner that is similar to the airway. Wherever the airway branches, there will be a gathered branches of pulmonary arteries. The small pulmonary arteries accompany the bronchi as they move down the lobules and branch to supply the capillary network that surrounded the alveoli. The oxygenated capillary blood is collected in a small pulmonary veins. You see, the process is vice versa. The deoxygenated blood present in the pulmonary arteries, while the oxygenated blood will be collected in the pulmonary veins. So the oxygenated capillary blood is collected in the small pulmonary veins of the lobules, and then it will move to the large veins to be collected in the 4 large pulmonary veins that empty into the left atrium. So the oxygenated blood will pass through these large pulmonary veins and will reach to the heart through the left atrium of the heart. Now, we talk very widely about the respiration, the oxygenation, and now we have to know what's the effect of hypoxia in the lung. What will happen when there is hypoxia? The blood vessels in the pulmonary circulation will undergo marked vasoconstriction when they are exposed to hypoxia. The precise mechanism for this response is unclear. For example, when the alveolar oxygen level drops below 60 millimeter mercury, there will be a marked vasoconstriction, and at a very low oxygen level, the local flow may be almost abolished. It will stop at the site when there is hypoxia. There will be a marked vasoconstriction when the oxygen level drops in this area, and at a very low oxygen level, the local flow may be almost abolished. I mean the local flow of blood in these vessels at the area of decreased oxygen level. In regional hypoxia, as occur with a localized airway obstruction, and for example in atelectasis, which is a pathological condition, there will be a localized area of airway obstruction. There will be a vasoconstriction, which is localized to a specific region of the lung. What is the importance of this vasoconstriction? Why when oxygen level in a specific area of the lung decrease, the response of blood vessels in this specific area of the lung will be a severe vasoconstriction. What is the importance of this phenomena? Vasoconstriction has the effect of directing blood flow away from the hypoxic region of the lungs. What the importance of this process? When alveolar hypoxia no longer exists, a blood flow will be restored. It means when a specific area of the lung have decreased oxygen level, this area will respond by maintaining a severe vasoconstriction of blood vessels. This will help in directing the blood flow away from the affected area into the other regions of the lung, which are healthy and able to maintain a normal gas exchange and a normal perfusion. Then, when this area is no longer affected by the hypoxia, blood flow will return to its normal condition. Okay. What happens if there is a generalized hypoxia? We were talking about a regional hypoxia. Now, what happens if there is a generalized hypoxia? Generalized hypoxia will cause a vasoconstriction throughout the lung. And this generalized vasoconstriction occurs when the partial pressure of oxygen is decreased. And for example, the partial pressure of oxygen decreased at high altitude, or it can occur in a person with a chronic hypoxia which caused by a lung disease. So, generalized hypoxia can cause a generalized vasoconstriction, and this is occur when the partial pressure of oxygen decrease in high altitude in a patient with a chronic lung disease, and this will affect a normal respiration. What is the effect of prolonged hypoxia on the pulmonary system? A prolonged hypoxia can lead to pulmonary hypertension, and that will increase the workload on the right heart. A low blood pH also produces vasoconstriction, especially when alveolar hypoxia is present. And as an example for this situation that occurs during circulatory shock. During circulatory shock will cause a low blood pH which produce vasoconstriction and alveolar hypoxia. As you remember, we talk about the ventilation of gases, the perfusion of blood, and now we have to understand the importance of diffusion. Sorry. Diffusion refers to the movement of gases in the alveoli and across the alveolar capillary membrane. And why we said the alveolar capillary membrane? Because at the site of the alveoli, the capillary is very close to the alveoli. So the surface of diffusion is across the alveolar capillary membrane. Diffusion of gases in the lung is affected by three important factors, which are the difference in the pressure of gas across the membrane. And as you remember, we talk about the importance of the difference of pressure in the pulmonary system. So the first is the pressure of gas across the membrane. The second is the surface area that is available for the diffusion. And finally, the thickness of the alveolar capillary membrane through which the gas must pass. So, diffusion is highly affected by the pressure of gases across the membrane, the surface area, of the membrane available for diffusion and the thickness of alveolar capillary membrane. The characteristic of the gases and its molecular weight and solubility constitute the diffusion coefficient and determine how rapidly the gas diffuses through the respiratory membrane. For example, carbon dioxide diffuses 20 times more rapidly than oxygen because of its greater solubility in the respiratory membrane. And this is important for our body because we need to get rid of carbon dioxide as early as possible and as easy as possible. What is help our body to get rid of carbon dioxide is its solubility. Its solubility so that it will diffuse rapidly than oxygen in the respiratory membranes. Another topic we have to understand is the matching between ventilation and perfusion. How our lung match between the ventilation and perfusion. The gas exchange properties of the lung depend on matching of ventilation and perfusion, so that ensuring the equal amount of air and blood are entering in the respiratory portion of the lung. What do this mean? We need an equal amount of air and blood to enter in the respiratory portion of the lung so that the perfusion and ventilation will match. What that mean? That mean I need an equal amount of gas and equal amount of blood to have a successful pulmonary function and a successful respiratory function. There are two factors that may interfere with the matching of ventilation and perfusion, and we have to understand these two definitions, which are the dead air spaces and the shunts. The dead air space refers to the air that must be moved with each breath but does not participate in gas exchange. And as you know, there are two types of dead spaces that contained in the conducting airways. The air that pass in the conducting airway, which is called the anatomical dead space. This gas that passes through the conducting airway will not participate in the gas exchange that occur in the alveoli. So, the anatomic dead space that contained in the conducting airways and the anatomic dead spaces that contained in the respiratory portion of the lung is called the alveolar dead spaces. That means the dead air space is composed of two portions, which are the conducting airways, which is called the anatomical dead spaces, and the part of respiratory tract of the lung, and that is not involved or not participate in the gas exchange, which is called the alveolar dead space. So, connectively, we can say that the dead air space is composed of the anatomic dead space and the alveolar dead space. And this constitutes the air that contained in the nose, pharynx, trachea, and the bronchi. Regarding the alveolar dead space, is there any alveolar dead space normally? Yes. Alveolar dead space normally is about 5 to 10 mol. It is a very small amount. The alveolar dead space normally is about 5 to 10 mol. And it constitutes the alveolar air that does not participate in the gas exchange. It is the part of the alveoli that is not participate in the gas exchange. What is its amount? Is a very small amount. It is about 5 to 10 mol. When the alveoli are ventilated, but they are deprived of blood flow. When the alveoli is ventilated, but there is no pulmonary capillaries near these alveoli do not contribute to the gas exchange and thereby constitute alveolar dead space. Now, what is the physiological dead spaces? The physiological dead space include the anatomic dead space plus the alveolar dead space. The physiologic dead space is the sum of anatomic dead space and the alveolar dead space. In persons with normal respiratory function, the physiological dead space is about the same as the anatomical dead space. What this mean? You understand the anatomic dead space, and we understand what is the alveolar dead space. And we said that the alveolar dead space have a very small amount, which is equal to 5 to 10 mol. So, when you are a healthy person, the physiological dead space, which is the sum of anatomical dead space and alveolar dead space, the physiological dead space will be about the same as anatomic dead space. Why? Because the alveolar dead space have a very small quantity. Okay. Let's go and understand what is the meaning of a shunt. Shunt refers to the blood that moves from the right to the left side of the circulation without being oxygenated. It is the blood that moves from the right to the left side of the circulation, but they are not oxygenated. There are two types of shunt, which are the physiological shunt and the anatomic shunt. In a physiologic shunt, there is a mismatch of ventilation and perfusion. As you remember, it is important to have a matching between the ventilation and perfusion. So, when there is a mismatch between the ventilation and perfusion, there will be a physiologic shunt, which result a mismatch of ventilation and perfusion will result in insufficient ventilation to provide the oxygen needed to oxygenate the blood following through the alveolar capillaries. So, physiologic shunt occur when there is a mismatch between the ventilation and perfusion, and this will lead to insufficient ventilation to provide oxygen needed to oxygenate the blood flowing through the alveolar capillaries. How our body interfere with this? It will react by producing a physiological shunt. Physiological shunt of blood usually result from destructive lung disease that impairs the ventilation, or from heart failure that interfere with the movement of blood through sections of the lung. So, it is occur either due to a lung diseases that interfere with the ventilation, or from a heart failure that interferes with the movement of blood through a section of the lung. In an anatomic shunt, blood will move from the venous to the arterial side of the circulation without moving through the lung. It will move from the venous to the arterial side of the circulation without moving through the lung. In this graph, as you see, this is the airway, this is the arterial blood, and this is the venous blood. These are the alveoli. Normally, the alveoli need a good ventilation and a normal perfusion. We need to produce a normal respiration. We need a good ventilation and a normal perfusion to maintain a normal respiratory function. As you see in this part, there is a good ventilation, but there is a defect in the perfusion. Okay, there is a closure to the perfusion, so there will be abnormal respiration. And on the other hand, in this alveoli, there is a normal perfusion of blood, but there is a closure to the ventilation. So the result will be abnormal respiration, abnormal respiratory function. The normal respiration require a normal ventilation and a good perfusion. Oxygen and carbon dioxide are carried by the blood. Blood carries oxygen and carbon dioxide in the dissolved state, and in combination, as you know, with hemoglobin. carbon dioxide also converted to bicarbonate and transported in this form, I mean the bicarbonate. The amount of gas that can dissolve in the plasma is determined by two factors. These factors are the solubility of the gas in the plasma and the partial pressure of the gas in the alveoli. So, the ability of the gas to dissolve in the plasma is determined by two factors, which are the solubility of this gas in the plasma and the partial pressure of this gas in the alveoli. So we have the partial pressure of the gas in the alveoli and the solubility of the gas in the plasma. The partial pressure of oxygen in the arterial blood is normally greater than 80 mm mercury, while the partial pressure of CO2 is in the range of 35 to 45 mm mercury. So, the hemoglobin in the red blood cells serve as a transporter vehicle for the oxygen. How? The hemoglobin will bind the oxygen in the pulmonary capillaries and release the oxygen in the tissue capillaries. Only approximately 1% of the oxygen in the blood is carried in the dissolved state. Okay? The remainder is carried in a combination with hemoglobin. And we have to think why 1% of the oxygen is carried in the blood in dissolved state, while 99% of the oxygen is carried by a combination with hemoglobin in the red blood cells. Okay. Hemoglobin with bound oxygen is called the oxyhemoglobin. From its name, it is a hemoglobin bound to oxygen, so it is called oxyhemoglobin. And when the oxygen is removed from the hemoglobin in the tissue capillaries, it will be called a deoxygenated hemoglobin or a reduced hemoglobin. Each gram of hemoglobin will carry about 1.34 mol of oxygen when it is fully saturated. Okay, I mean the hemoglobin is fully saturated. When the hemoglobin is fully saturated, it will carry approximately 1.34 mol of oxygen. As the oxygen moves out of the capillaries in response to the needs of the tissues, the hemoglobin saturation, which is usually 95 to 97% as the blood leaves the left side of the heart, will drop approximately 75%. What does that mean? When the blood leaves the left side of the heart, the oxygen saturation in the hemoglobin is 95 to 97%. It means that the hemoglobin is fully saturated with oxygen. Okay? When the blood leaves the left side of the heart. Blood, when leave the left side of the heart, the blood is fully saturated with oxygen, and the saturation reached to 97%. While when this blood reaches to the tissues and the oxygen moves out of the capillaries in response to the tissue needs, the saturation of hemoglobin with oxygen will drop, but to about 75% only. You have to think about that. Why the saturation of blood with oxygen not drop less than 75%, which is very important for body to maintain a normal oxygen saturation and to maintain normal functions. So we understand that oxygen is carried by the oxygen carrying vehicle, which are the hemoglobin, and we understand that the hemoglobin, when fully saturated with oxygen, it can carry about 1.37 mole of the oxygen. And when the blood leaves the left side of the heart, it is fully saturated with oxygen, and the saturation rate can reach to 97%, while when the oxygen dissociated from the hemoglobin as it passes to the tissue, the oxygen saturation will drop to 75%. What is the oxygen hemoglobin dissociation? Oxygen that remains bound to the hemoglobin cannot participate in tissue metabolism. Why? Because this oxygen, it is bounded to the hemoglobin. It can not help the cells in oxygenation. So, the efficiency of oxygen dissociation transport system depends on the ability of hemoglobin molecule to bind to oxygen. As the ability of hemoglobin molecule to bind to oxygen increase, so it will be more effective. Okay. This ability of hemoglobin requires that the hemoglobin molecule bind oxygen in the lungs and release it as it is needed in the tissue. Why? Because if the oxygen remain binding to the hemoglobin, the tissue will not be able to use this oxygen. The tissue will not be able to use this oxygen if it is still bounded to the hemoglobin. So we need the hemoglobin molecule to be able to bind to oxygen in the lung, and also we need the hemoglobin molecule to be able to release this oxygen as it is needed in the tissue. So the affinity of hemoglobin refers to the capacity of hemoglobin to bind oxygen. Hemoglobin binds oxygen more readily when its affinity is increased. The affinity is the ability or the capacity of hemoglobin to bind oxygen. When the affinity increases, so it will bind more oxygen. Hemoglobin binds oxygen when its affinity increases, and hemoglobin will release the oxygen when its affinity decreases. The hemoglobin molecule is composed, as you know, of 4 polypeptide chain bound to an iron-containing heme group. Because oxygen binds to the iron atom, each hemoglobin molecule can bind 4 molecules of oxygen. I think it is clear, because the hemoglobin molecule containing iron containing a 4 polypeptide chain bound to iron, so the oxygen will bind to the iron atoms as they are 4 in number. So a hemoglobin molecule can bind to a 4 molecule of oxygen. When oxygen is bound to all the 4 heme group, so we can say that the hemoglobin molecule is fully saturated. Okay? When oxygen is bound to the all 4 heme groups of the hemoglobin molecule, we can say that the hemoglobin molecule is fully saturated. The hemoglobin affinity for oxygen influenced by different factors. The most important one is the pH, the carbon dioxide concentration, and the temperature. Hemoglobin binds oxygen more strongly under condition of increase the pH. It means the alkalosis. Okay? When there is an alkalosis in the body, so the hemoglobin affinity towards the oxygen will increase, so the hemoglobin will bind oxygen more strongly. Okay. Decrease carbon dioxide concentration and decrease body temperature will cause the hemoglobin to bind oxygen more strongly. Hemoglobin will bind oxygen more strongly when there is increase in the pH, when there is decrease in the carbon dioxide concentration, and when there is decrease in the body temperature. We can explore the relation between the oxygen carried in a combination with hemoglobin and the partial pressure of oxygen of the blood in what is called the oxygen hemoglobin dissociation curve. What we talk about the affinity of hemoglobin towards the oxygen and the ability of hemoglobin to attach to oxygen and the ability of hemoglobin to dissociate from the oxygen. This relation between the oxygen carried in combination with hemoglobin and the partial pressure of oxygen is described by the oxygen hemoglobin dissociation curve. This is the oxygen hemoglobin dissociation curve. The oxygen hemoglobin dissociation curve have a plateau region. It have a flat top portion representing the binding of oxygen by hemoglobin in the lung, and a steep portion which represents the release into the tissue capillaries. This is the plateau portion and this is the steep region. The steep region represent the release of oxygen in the tissue, and the plateau region represent the oxygen in the lung. The flat top portion or the plateau region represent the binding of oxygen with hemoglobin in the lung, and as we mentioned, the steep portion represent the release of the oxygen into the tissue capillaries. The S shape of the curve reflects the effect that oxygen saturation has on the affinity of hemoglobin for oxygen. And this is the S shape. This is the S shape of the oxygen hemoglobin dissociation curve. Okay. The S shape of the curve reflects the effect that oxygen saturation has on the affinity of hemoglobin for oxygen. At approximately 100 millimeter mercury partial pressure of oxygen, a plateau occurs. What this means? When there is a complete saturation of hemoglobin with oxygen at approximately 100 millimeter mercury of partial pressure of oxygen, a plateau occurs, at which point the hemoglobin is approximately 98% saturation. The hemoglobin is completely saturated with oxygen. It means that the four heme parts of the hemoglobin molecule are saturated with oxygen. So a plateau will occur. It will not increase in its affinity. Then, hemoglobin affinity for oxygen must change with metabolic needs of the tissue. This change is represented by a shift to the right or to the left. The hemoglobin affinity for oxygen must change with metabolic needs, and this is represented as a shift to the right or a shift to the left in the oxygen hemoglobin dissociation curve. A shift to the right indicates that tissue PO2 is greater for any given level of hemoglobin saturation and represent a reduced affinity of hemoglobin to oxygen. Why? Because, as we said, the tissue partial pressure of oxygen is great. The tissue is saturated with oxygen. In this condition, the affinity of hemoglobin to oxygen will decrease. So there will be a reduced affinity of hemoglobin for oxygen at any given PO2. It is usually caused by conditions such as fever or acidosis, or by increase the partial pressure of CO2, which reflects an increase in tissue metabolism. So a shift to the right indicates that the PO2 in the tissue is greater and there is a reduced affinity of hemoglobin to oxygen, and it is caused by conditions such as fever, acidosis. As you remember that increased affinity of hemoglobin towards oxygen occur in alkalosis, while decreased affinity will occur during acidosis. Okay, or by increase the partial pressure of CO2, which reflect increased tissue metabolism. A condition such as a high altitude pulmonary insufficiency and heart failure, or patients with severe anemia also cause the oxygen dissociation curve to shift to the right. Okay. if you can search why severe anemia will cause a shift of the oxygen hemoglobin dissociation curve to the right, it will be great to know what is the cause of this shift. Okay. On the other side, a shift to the left in the oxygen hemoglobin dissociation curve represents enhanced affinity or increased affinity of hemoglobin for oxygen. A shift of the oxygen hemoglobin dissociation curve to the left indicates an increased affinity of hemoglobin for oxygen, and occurs in a situation associated with decrease in tissue metabolism. Where this occurs, it occurs in conditions such as alkalosis, decreased body temperature, and decreased carbon dioxide level. So, in anemic person may have a normal partial pressure of oxygen and hemoglobin saturation level, but a decreased oxygen content occur because of low amount of hemoglobin for binding the oxygen. What does that mean? That means the defect in anemic person is not in the oxygen, but the defect is because there is a low amount of hemoglobin available for binding oxygen. Okay. We complete our lesson, and this is the last lecture in